Welcome to Hematology and Vascular Physiology. Let's kick off this lecture series by discussing pharmacology of the blood, specifically the types of drugs that we're going to use to control what happens in the blood. So anticoagulants, okay, these are going to inhibit the coagulation of blood. And the most important are things such as heparin and warfarin. The antithrombotics, these are drugs that are going to prevent the aggregation of platelets. So aspirin, clopidogrel, taclopidine, cilostazol, dipyridamol. And we're going to go through all of these drugs momentarily. Then we have thrombolytics, and their job is to degrade clots that have already formed. So they're going to bust up clots. These drugs include streptokinase, urokinase, tissue plasminogen activator, and there's a few more, and we'll go over all of those. Okay. Then we have hematopoietic drugs. These are epoetin alpha, filgrastim, sagromostin, and oprevokin. And we'll discuss what all of these hematopoietics are going to do momentarily. First up are our anticoagulants. This includes heparin and warfarin. Now these are really high-yield drugs, so it's important that we know what they do and how we can compare them to each other. Okay, so we want to know, with respect to each one of these drugs and all the others, their mechanism of actions, their use or indication, as well as any adverse side effects. So let's discuss heparin and warfarin. First thing we want to know is the mechanism of action. So if we look at the mechanism of action of heparin, we know that it binds to antithrombin 3 or AT3. And this AT3 complex is then going to bind to and inhibit activated clotting factors. Whereas if we look at the mechanism of action of warfarin, it's going to antagonize vitamin K. And when it does this, it interferes with the synthesis of all vitamin K dependent clotting factors, which are factors 2, 7, 9, and 10. Next up, what are the uses or indications of heparin and warfarin? Well, heparin, its use is for post-operative prevention of both DVTs and PEs. So we want to prevent a DVT or a deep vein thrombosis so that we don't subsequently develop a PE or a pulmonary embolism. Now, the important thing with respect to using heparin is to know that it works immediately. That's why we give it first. And this is going to be administered in IV format. Now, when we look at warfarin, its use is for DVT as well. But this is long-term therapy. Anytime someone has a pulmonary embolism, we're going to use warfarin for at least 6 months. Warfarin is also indicated for any patient who has valvular problems. Do they have artificial valves? So did they have a valve that was so damaged that it needed replacing? History of rheumatic heart disease. These are all conditions that warrant the use of warfarin. Now, it's important to realize that warfarin is oral as opposed to heparin, which was given in IV form. Okay? And warfarin is going to cross the placenta, so we never want to give warfarin to a pregnant patient. Okay? Now, what are the adverse effects when we look at heparin and warfarin? Well, bleeding is a major adverse effect for both, as is hemorrhage. Now, necrosis is a term that we can assign to both of these drugs. Heparin, however, you're only going to see necrosis at the site of injection, whereas warfarin, we can see a necrosis anywhere. Now, when it comes to heparin, the most worrisome and most severe side effect is something known as heparin-induced thrombocytopenia. Anytime this condition develops, we have to stop any of our heparin products, whether it be regular or low molecular weight heparin, and administer agatroban, which is a direct thrombin inhibitor. Now let's go through our list of antithrombotics. Okay, now aspirin is commonly used in very high yield. So let's go through the mechanism of action, its uses, and its unique adverse side effects. So how does aspirin work? It's going to inhibit the cyclooxygenase or COX enzymes. These are necessary for the formation of thromboxane A2 as well as prostaglandins. And together these are responsible for platelet aggregation. Now prostaglandins are important for keeping the lining of the stomach protected from stomach acids. So you're going to see with long-term use of aspirin that patients tend to get erosions in the stomach. Okay. Why do we use aspirin? Analgesia, right? Pain relief, anti-inflammatory properties, and it's antithrombotic. Okay, so the antithrombotic purposes are to decrease a myocardial infarction risk in any patient who has unstable angina or who has a history of infarction. Okay, it's also very effective in reducing the risk of recurrent TIAs, transient ischemic attacks. Now, a TIA is a syndrome that presents with stroke-like symptoms, but they subside within 24 hours. And the main adverse effects associated with aspirin use are going to be bleeding, and this could possibly lead to hemorrhage if severe. We also see GI ulceration, and as I mentioned, that's due to the blockage of prostaglandin synthesis in the stomach. That's going to provide a protective layer in the stomach against that very acidic environment. So if we block prostaglandins, the acid has a greater chance of reaching the stomach lining and causing ulcerations. Then we have taclopidine, and this is a drug that we usually reserve for patients who simply cannot handle or tolerate aspirin. So its main use is going to be to decrease stroke risk in those who can't tolerate that drug. Okay, how does it work? It irreversibly blocks the binding of platelets to fibrinogen. Okay, it also blocks a degranulation of platelets. Its adverse effects include increased risk of bleeding, as you'll find with all the antithrombotics, as well as very significant complaints in the nausea, vomiting, and diarrhea department. Okay, one of the most unique and important side effects associated with taclopidine is that it can cause neutropenia. This means that it's going to block the formation of all of our white blood cells. So what we want to do in any patient who's using taclopidine is get regular CBCs. We want to watch the levels of our white blood cells, make sure they're normal, so that our patient isn't at an increased risk of infection. Next up is clopidogrel. This drug is also known as Plavix, a highly marketed drug. You've definitely seen it on TV. And while you don't have to know these trade names like Plavix or, for example, Viagra or Cialis, you just have to know the generic names. But this one is just so common that it's worth your while to at least know it. How does clopidogrel work? Well, it blocks platelet aggregation by inhibiting the ADP receptor. Okay, this subsequently blocks platelet aggregation. And we're going to use this to reduce the number and the risk of atherosclerosis. When we decrease the risk and the amount of atherosclerosis that develops, we're going to see a decreased risk for strokes, for myocardial infarctions, or for any other ischemic events. And the main adverse effects of using clopidogrel are bleeding, the potential for hemorrhage, as well as GI ulcerations. Next up is cilostazol, and this is a drug that we use for patients who have a condition known as intermittent claudication. And this is simply ischemic-like pain in the lower extremities. And typically the way it presents is patients will tell you that they have significant pain in the glutes as well as the legs whenever they're trying to walk. So they'll have a very low tolerance to walking even more than just 10-20 feet. This is also known as Leriche syndrome. It's also very highly associated with impotence, so that's something to keep in mind too if you're questioning a patient. Okay, so why is this drug effective in Leriche syndrome? Well, it inhibits phosphodiesterase 3, which is a receptor found mostly in the lower extremities. And this leads to dilation of the blood vessels in the lower extremities. And what that does is it increases blood flow and it alleviates pain. With increased blood flow, we're going to have a greater oxygen delivery. Okay, so you'll see a pain decrease with the use of cilostazol. Now, the side effects associated with this drug are cardiac related. They include things such as palpitations, okay? And we may also see headache. That's due to the vasodilatory effects of cilostazol. Next up is dipyridamole. Now, if this is used on its own, it's not very effective. Therefore, we're always going to use it together with a couple of drugs. If we combine it with warfarin, the overall therapeutic benefit is that we're going to prevent emboli from growing on artificial valves. If we use it with aspirin, we're going to see decreased platelet lifespan in patients who have thrombotic diseases. So look for it combined with warfarin or aspirin. Now, how does dipyridamole work? It inhibits the phosphodiesterase enzyme. This is subsequently going to lead to an increased level of cyclic AMP. This in turn potentiates PGI2, which is a platelet aggregation inhibitor. Okay, so you can see how that's going to work. It also works to increase the levels of adenosine. This is an effective compound because it's going to dilate the vessels of the heart, most importantly the coronary artery. Okay, so it's multi-beneficial. Now, the adverse effects associated with dipyridamole are going to be exacerbation of angina. Okay, it can cause dizziness, it can cause headache, it can even cause syncope. Okay, and as with all of these, it can also lead to GI problems. Now we're going to move into the thrombolytics. The first one we're going to discuss is streptokinase, and we use this for the coronary arteries after infarction. And we're only going to be using streptokinase if we're dealing with ischemic vessels, not necrotic vessels. Okay, so ischemic meaning they've been exposed to a lack of oxygen, whereas necrotic vessels are actually dead. They've necrosed because of a lack of oxygen. Okay, this drug is also effective for PE, pulmonary embolism, for DVT, as well as for peripheral artery thrombosis. Okay, how does this work? The MOA of streptokinase is that it's going to activate plasminogen into plasmin, and plasmin in turn will digest both fibrinogen and fibrin. And this digestion is what gives us the degradation products. These are effective in acting as anticoagulants because they're going to directly inhibit the formation of fibrin. Okay? And what you're going to see as common adverse side effects or adverse effects of streptokinase are bleeding, bruising, and very rarely we may see anaphylaxis. Next up, we have urokinase and anistriptase, and these both have the same mechanism of action, use, and adverse effects of streptokinase. Next up, we have TPA, or tissue plasminogen activator, and we're going to use this for the reperfusion of any occluded artery. Okay, how does it work? It binds to fibrin and it activates fibrin-bound plasminogen into plasmin. The adverse effects associated with TPA are hematoma at the site of catheterization. So anytime you see a catheter and a big hematoma, you always want to be thinking about TPA, or you might want to think about heparin. Next up, we have alteplase and retiplase, and these are similar to TPA because their mechanism is to bind to fibrin. And we're going to use these for cases of acute MI. Both of these drugs are going to be effective. And if we are talking about ischemic stroke and pulmonary embolism, alteplase alone is going to be the most effective option. And the main side effect associated with these are going to be bleeding. Next, we have three drugs that we can think of as being together: abciximab, abtifabetide, and tirofiban. And we're going to use these for cases of acute coronary syndrome. And the way they work is that they're going to inhibit the glycoprotein 3B, or G3B. This is necessary for platelet aggregation. So by blocking that, platelets won't aggregate. And the main side effect with this one too, as with most of the others, is bleeding. And finally, there's four important hematopoietic drugs we need to know. The first is apoetin alpha, and this is a recombinant of erythropoietin. And erythropoietin comes from the kidneys whenever a patient is in either a hypoxic situation or is anemic. And the goal of giving this drug is to stimulate erythropoiesis. So why do we need this? Well, in cases of renal failure, we can't synthesize erythropoietin. So the use for apoetin alpha is either a hypoxic or anemic patient who also concurrently has chronic renal failure. The second drug is filgrastim. This is a human recombinant granulocyte colony stimulating factor. What this does is it stimulates neutrophils from the progenitor cells. And we're going to use this when using any myelosuppressive drug. Okay. Now, the goal of administration of filgrastim is to prevent neutropenia. Okay, because neutropenia, let's say if we have a patient with cancer or any other significant issue, if we don't manage the neutropenia, this can lead to an increased susceptibility to infections, and if they're already fighting some sort of major disease, these infections can be fatal. Sargramostrum is a drug that we use to accelerate bone marrow replenishment whenever a patient undergoes bone marrow transplant. So this is a human recombinant macrophage colony stimulating factor, and it's going to stimulate all blood cell lines, so granulocytes, macrophages. However, it's not going to stimulate megakaryocytes, which are going to eventually lead to platelets, nor is it going to stimulate erythrocytes, which lead to our red blood cells. So we're looking at stimulation of white blood cells, or our infection-fighting blood cell line. And the last one is oprelvacin. This is going to stimulate the production of platelets. Now, we use this after chemotherapy. Whenever we see that the patient's platelet count is low, if we give this, it can work to very nicely boost that platelet count in order to prevent any type of excessive bleeding. Now we're going to discuss the ESR, which is the erythrocyte sedimentation rate. Now, what the ESR is testing essentially is the speed at which a red blood cell will settle when we put it into a tube. Now, the tube we use is known as a Westergren tube, and these tubes are measured in millimeters, and the way we measure ESR is going to be in millimeters per hour. So whenever you see the ESR's number it's referring to how many millimeters it moved in an hour. Now first, let's discuss what normal ESR is. Normal for a male is anywhere from 12 to 20 millimeters per hour, and with increased age, the ESR increases. So that was with a male. If we're talking about a female, the average is approximately 18 to 23 millimeters per hour. And the same thing, as we have an increase in age, we tend to have an increase in your ESR. Okay, so those are normal values. Don't forget we measure in millimeters per hour. So when we want to take an ESR, here's what we're going to do. We're going to take a sample of blood, and we are going to mix that with an anticoagulant, because if we didn't put an anticoagulant in with that blood, it would just form a big clot. So we take blood and we take an anticoagulant, we put it into the tube, and then we wait for 1 hour. After the hour is passed, we get a tube that looks like this. Our red blood cells have started to settle at the bottom. Okay, they've sedimented, or they've created a sediment, and then what we have up here is the remainder of our plasma. Now, we discussed the normal values, but there's also a calculation that we can use in order to determine the actual ESR. Typically, ESR is going to be less than or equal to the age of the person in years plus 10 if we're dealing with a female, divided by 2. So that's a simple calculation we can use to determine what the ESR should be. But what if we get our ESR back from the lab and it's greater than normal? Anytime the ESR is elevated, that's going to be an indication for some sort of inflammatory process. But remember, this is a non-specific type of test. It's not going to tell us exactly what's wrong. It's just going to tell us that there is something wrong. And then at that point, it's our job to determine what's actually going on. Now, understanding why we see an increased ESR is fairly straightforward. First thing you need to know is that anytime there is inflammation within the body, the liver is going to spit out a bunch of proteins. Now, one of the most important proteins when it comes to ESR is a protein known as fibrinogen. The second thing to keep in mind here is that when we look at a red blood cell, we have to remember that around each red blood cell are lots of negative charges. So the presence of all of these negative charges is important because what it does is it actually acts to repel red blood cells from one another. Now, in an abnormal situation where we have lots of fibrinogen, these fibrinogen proteins come in and around your red blood cells, and they're loaded with positive charges. As a result, what happens is all of these negative charges get sort of neutralized, and so all of a sudden we have red blood cells that don't have these negative charges, they're neutral, and all of a sudden they can start to stick to each other. And the way they like to stick to each other is sort of in a stacking formation. They stack on top of each other. And this is known as rouleau formation. We see this with other conditions, particularly with multiple myeloma. And overall, the more fibrinogen that we have from the inflammatory process, the more neutralized these red cells become and the greater size the rouleau formation will be. As a result, what's going to happen is these are going to fall and sediment faster. And when they sediment faster, we get an increase in our ESR. And that's all you really need to know in order to understand exactly what's going on when we see an increased ESR. Now, we mentioned how proteins such as fibrinogen will neutralize these red blood cells which have negative charges. Something else that has lots of positive charges that can neutralize the red blood cell is an antibody. An antibody contains positive charges, and this will act to neutralize those red blood cells in the exact same fashion. So the reasons why we see an increased ESR are usually due to inflammatory processes. They can also be due to autoimmune processes, right? So conditions such as rheumatoid arthritis, multiple myeloma, infections, Okay, these are all things that either create antibodies or they create inflammatory mediators that lead to an inflammatory reaction. And all of this is going to give you the increased ESR for the same reason. It's our job to recognize that ESR is nonspecific and then to dig a little deeper and figure out exactly what's going on.